Hello, welcome to video 2 of our 3-part video series answering frequently asked questions regarding pediatric respiratory tract infections. My name is Kristin Schmidt. I am an infectious diseases and antimicrobial stewardship pharmacist in Regina, and I am joined by Dr. Rupesh Chawla, who is a pediatric infectious diseases and antimicrobial stewardship physician in Saskatoon. The objective of this video series is to answer frequently asked questions regarding assessment and treatment of common pediatric respiratory tract infections encountered in primary care, with the aim of ensuring that antimicrobials are used as appropriately as possible. This video will cover acute sinusitis in pediatrics. So to begin with, I will pass things over to Dr. Chawla to give a bit of a background before we jump into the questions.
Thank you so much, Kristin. I'm just going to be pulling up my slides here. So hopefully you joined us on the first episode, but this is our second episode that we're going to be talking about acute bacterial sinusitis and sinusitis. So just to, like we started before, the one thing that I would strongly recommend to anyone who's following along and takes care of kids is that we really would like you to download the First Line app, which is available for free on both the Apple Play and Google Store, especially if you maintain at the very top, make sure you download at the top when you see which section, the Mom and Kids or the Jim Pattison Children's Hospital. It will give you the pediatric guidelines as well as pathogens and antimicrobial information for pediatric patients when you're accessing it for this information. So next, we're going to talk a little bit about bacterial sinusitis today. So sinusitis does start as a viral illness, but in about 0.5% of adults, but in a much larger percent in kids, 7 to 10%, this can become a bacterial illness. I think this is one of those situations that we actually do undertreat in certain circumstances in children of bacterial sinusitis. So I think it's an important topic to talk about because they can have some significant secondary complications that can be quite significant. Thanks, Kristin. Well, take it to questions.
All right. Let's answer the questions. So for the first question, what differentiates the clinical presentation of bacterial versus viral sinusitis?
So as we said before, all of these start as a viral illness. And bacterial sinusitis, the way you diagnose it, it's truly a clinical diagnosis. There's no, we'll talk about this later, there's no special physical exam techniques, no special radiologic imaging, there are special blood tests that will tell you what's going on. Basically, a change to a bacterial sinusitis is one of the 3 presentations that's listed below. So most viral illnesses will disappear by 7 days. If you have persisting symptoms or persistent illness without improvement with nasal discharge, obstruction, congestion, for over that 7 to 10 that can progress up to even 30 days, that is one of the criteria that you would say that there's an acute bacterial sinusitis in children and would consider antibiotic therapy. Second is if you have an initial recovery from that viral illness, so that initial URTI, and then a worsening, a secondary worsening around day 6 to 7 with nasal discharge, congestion, cough, and a return of fever, that is another secondary presentation of an acute secondary bacterial sinusitis. And then thirdly, you can also see almost an acute rapid change to a bacterial sinusitis. We have very severe symptoms, high-grade fever, purulent nasal discharge, concurrently with at least 3 to 4 days. And often those situations, the sinuses can actually be very tender as well.
Okay, moving on to question number 2. Does the color of the drainage tell us anything? So does it matter if it's yellow or green?
A great question, Kristin. I get asked this by parents all the time. Well, it's really green or it's very thick and yellow. There is no color of the nasal discharge that makes it more likely to be viral or bacterial. It's just as we talked about, the length and those clinical presentations that can make the difference. The one caveat to that rule is that if they do have very clear, basically like water, nasal discharge, and if it's associated with other allergic symptoms like runny nose, sneezing, and also sort of palatal itchiness, maybe think about whether you're dealing with a sinusitis or is this truly an allergic rhinitis that we're dealing with, and that will not improve with antibiotics.
Yeah, that's a great distinction. So question number 3, are sinus x-rays or other radiologic investigations or transillumination of the sinuses helpful at all in making this diagnosis?
So thank you for asking this question, Kristin. I really want to reinforce this, that acute bacterial sinusitis is a clinical diagnosis. It's based on your symptomatology, your course of illness, and physical examination. Definitely, if it's tender over the sinuses, it makes a difference. But transillumination of the sinuses, though it looks really cool in images, it really doesn't make a difference and really doesn't tell you if you have a sinusitis or not. The symptoms listed there below are very common symptoms that you can have. Again, depending on the site of the sinus that you have it, you can actually see some other sort of more unusual symptoms like tooth pain, some malodorous breath can also be part of this. And most importantly, x-rays really, especially sinus x-rays, have no role in the diagnosis of sinusitis. You can see abnormal imaging even with a cold. You can see these mucosal thickenings, diffuse opacifications, and oral fluid levels on sinus x-rays in patients with colds. That does not mean they require antibiotic therapy. Again, it really depends on your clinical presentation. The only imaging that there is of some benefit in patients with sinusitis is CT scans, and that is of course not for the diagnosis of acute bacterial sinusitis, but looking for secondary complications of sinusitis or in operative planning.
Great. So moving on to treatment then, what would be our antibiotic of choice if we truly have a bacterial sinusitis present, and what would be the recommended duration of therapy?
Thanks, Kristin. So the antibiotic of choice for acute bacterial sinusitis, like most respiratory infections, is really pushed towards the treatment of strep pneumonia. It is really the major organism that's causing the infection and a lot of the symptomatology. So realistically, the first-line therapy for acute bacterial sinusitis, like otitis media, if you remember from our first video, is amoxicillin. Now, we talked about resistance factors, so we'll just go over that again. So resistance factors for strep pneumoniae are 3 things, and 2 are probably more important. So the presence of being in daycare. Second, if they've been on antibiotics, especially in the last 3 months. And third, young age, under 5, especially under the age of 2. So if you have the presence of especially one of the first 2, the daycare or the presence of being on antibiotics, you do want to use the possible resistance dosing. But if you have none of those, the basic statement is you should use amoxicillin at standard dose, which is 40 to 50 milligrams divided TID for the 10 to 14 days. If there's possible resistance, you can go up to the 80 to 100 milligrams divided BID for 10 to 14 days. You can only use that BID dosing when you're using the high dose, because that will maintain that antibiotic level at high enough levels to cause killing of the strep pneumonia. You can also, and we talked about this before, is in regards to allergy. Remember, this is a highly overreported, and there is a module within First Line to talk about how you make the diagnosis of true penicillin allergies. If you have true penicillin allergy, you can use other agents, such as with a true type 1 anaphylactic allergy. You want to avoid the penicillins completely in that group and that family, so you would use something like a macrolide, like a azithromycin or clarithromycin. And if you have a non-type 1 allergy, you can use an agent like cefuroxime or cefprozil. Second line, however, if you fail therapy with the amoxicillin or at the first dose or another first-line agent, you can use the second-line agent, which would be clavulin. Clavulin should not be used as your first-line therapy for sinusitis. This is, again, like we talked about before with otitis media, to cover other agents like H. influenza and Moraxella that may be additively causing problems. But realistically, that should only be used in a situation where you failed first-line therapy. And again, in terms of the dosing, you want to use the same resistance patterns. If you've had no resistance, use the standard dosing of clavulin at 40 to 50. And if you have possible resistance with the risk factors, the 80 to 100 milligrams of the clavulin dosing.
Fantastic. couple reminders for our viewers. We included in the bundle an amoxicillin and amoxiclav dosing handout, so when in doubt, you can refer to that. And also for a lot of these patients that you'll see in clinic, who you assess and deem to have a viral infection, there is another tool at your disposal, the viral prescription pad, which is available from Choosing Wisely and RX files that you can give to parents to help them manage symptoms and reinforce the fact that antibiotics aren't needed. So thank you so much, Dr. Chawla, for this, and thanks also to our viewers. So please check out the other videos in this series, as well as the other resources included in the bundle. If you'd like to further this discussion, we invite you to attend a webinar and Q&A session with both myself and Dr. Chawla, which will take place during World Antimicrobial Resistance Awareness Week on November 21st at 12 p.m. We hope to see you there.
Thank you so much, Kristin.